Okay, so we want to continue. We want to continue with our lecture. Yeah, and remember we stopped at ganglion blockers. We started with centrally acting sympatholytic drugs. We gave examples like clonidine, methyl dopa, guanabens, guanafacin. Then we came to ganglion blockers, of which we gave examples like hexathonium. Now, we want to continue with another group of antihypertensives, yeah, and these are known as postganglionic sympathetic nerve ending blockers. They are referred to as postganglionic, yeah, sympathetic sympathetic nerve ending blockers. And so if you are to rub off, basically postganglionic, they basically they function at these points, yeah. Postganglionic, they basically function at postganglia, after the ganglia. That is what it means, yeah. So postganglionic basically function at these points, yeah. That point, yeah. That point, yeah. That point and that point. So that is basically postganglionic. Postganglionic sympathetic nerve ending blockers. Now, if I may rub off this, because we have finished this already, I want to show you what actually happens, or what is their mechanism, of action. Yeah, that's what we want to look at. What is the mechanism of action of those postganglionic nerve ending, sympathetic nerve ending blockers. So if you allow me to rub off this, if you would allow me to rub off this, I will demonstrate what actually happens. All right, so it's not getting out, it's not getting off well. Let's rub it off with some alcohol. All right, so to demonstrate what actually happens normally is that if this is your nerve, your preganglionic fiber, yeah, something like that, yeah, something like that. That is your preganglionic nerve fiber, and then we have something like that, and then if I can demonstrate to you, assuming this is our just for purposes of illustration, assuming this is our postganglionic nerve fiber. Yeah. So what actually happens is that remember, normally, as we had said earlier on, these whatever, they concentrate tyrosine, which is converted into dopa, which is then converted into, of course, the enzyme here is tyrosine hydroxylase. Yeah, it is done from dopa to dopamine, then into the vesicles, as we said earlier on. Yeah, so this dopa is pumped into the vesicles by the monoamine, monoamine transporters, yeah, monoamine transport mechanisms. And then once it is converted, once it is within the vesicles, then it is converted into norepinephrine. So we are saying that once that dopamine is pumped into the vesicles, then inside there's an enzyme that basically converts it to norepinephrine. Yeah. Now, normally, as earlier on mentioned, what happens is that once there is an action potential, this norepinephrine is basically released. Yeah, this norepinephrine comes to the surface. It comes to the surface of the vesicle, and then it is released. Yeah, it is released, to the effector, assuming this is our effector organ. Like example, in this case, the blood vessel. Yeah. So we have receptors here. Yeah. We have adrenergic receptors here, where norepinephrine, where norepinephrine will act. Yeah. Now, remember we said also that we have what? What do we have? We have alpha 2 receptors, yeah, that are basically cause the negative feedback mechanism. So alpha 2 receptor, and so when we have this alpha 2 receptor, when it comes there, it causes stimulates this to basically cause a negative feedback, yeah, to stop release of norepinephrine. Yeah. Now, the other thing that is very important that we had not mentioned or we had not talked about at this point is that this norepinephrine, once it is released, it does not stay here forever. Yeah, it does not stay here forever. But there are mechanisms that basically transport it back. Yeah, there are mechanisms that transport it back into the vesicles. I want to repeat, is that once this norepinephrine is released, it does not stay here forever. Yeah, there are mechanisms that transport it back into the vesicles. Are we together? There are mechanisms that transport it back into the vesicles. Also worth mentioning is the fact that within these vesicles, we have an enzyme called monoamine oxidase. Yeah, so we have an enzyme called MAO. within outside of the vesicles, within the nerve ending, we also have an enzyme called monoamine oxidase. Monoamine oxidase. So that monoamine oxidase, what it does is that if we have a monoamine, like for example norepinephrine, dopamine, that is basically outside of the vesicles, then it is destroyed. Yeah, it is destroyed by this monoamine enzyme. Yeah, so the monoamine oxidase, basically its role is to destroy the extra monoamines that are basically not within the vesicles. In other words, if this norepinephrine is not pumped back in the vesicles, then it would be destroyed by MAO. It will be destroyed by monoamine oxidase. Is that clear? Because this is going to form the basis of our postsynaptic, postganglionic sympathetic nerve ending blockers. Yeah. So it is destroyed if it is outside of the vesicles. Yeah. Now, so basically, what actually happens is that there are some drugs that when they are given, yeah, there are some drugs that when they are given, they are basically pumped into the nerve ending, and then later pumped when those drugs are given. Those are the examples we are going to talk about. There are some drugs that when they are given, they basically enter, or they basically start working on along this system. Yeah. What actually happens is that those drugs are pumped, yeah? They are pumped by this mechanism back into, they are pumped by this mechanism that basically pumps norepinephrine, and they pump them into the nerve ending. They are pumped into the nerve ending, and later they are pumped by the, by the monoamine, transporters mechanism, by the monoamine transport mechanism into the vesicles themselves. I want to repeat. There are some drugs that when they are given, they go through this mechanism or this process. They are pumped from this point into the nerve ending, and eventually into the vesicles. And eventually into the vesicles. And as a result, what happens? They are pumped, they tend to concentrate in the vesicles. They tend to concentrate in the vesicles. And as a result, once they concentrate in the vesicles, they push the norepinephrine out of the vesicles. They push the norepinephrine out of the vesicles because themselves they are pumped into the vesicles and they concentrate in there. They concentrate in the vesicles, and as a result, they start pumping them. They cause the norepinephrine to come out of the vesicles. And when they're out of the vesicles, ladies and gentlemen, remember we said they are destroyed. When they are out of the vesicles, they are destroyed by MAO. So when norepinephrine comes out of the vesicles, it is destroyed by this enzyme monoamine oxidase. So what actually happens is that if norepinephrine is destroyed, when we have an action potential, what will be released? It is not the norepinephrine. Instead, it is those drugs that have been concentrated in the vesicles that will be released, and not norepinephrine. And therefore, we shall not have an action potential proceed to the effector. We shall not have an action potential proceed to the effector organ. Yeah, we shall not have an action potential proceed to the effector organ, and as a result, since we do not have an action potential, since we do not have norepinephrine being released, so the effects will be seen, of what we have actually seen earlier. That we shall not have an increase in heart rate. We shall have vasodilatation, and as a result, we shall have a decrease in pressure. Now, what are some of the examples of these drugs that basically get concentrated in the vesicles? A very good example of this drug is what we refer to as guanadrel. Guanadrel, yeah, guanadrel, yeah. So that's a very good example of a drug that when it is given, it is taken by this mechanism, it concentrates in the vesicles, then it pushes the norepinephrine out, which norepinephrine is now destroyed by the monoamine oxidase. And when action potential comes, when an action potential comes, there will not be release of norepinephrine. Instead, it is that drug which will be released, and of course, it will not produce any kind of effect since it is not norepinephrine. Okay, another example of a drug which basically acts in such a way, but not specifically like guanadrel, is a drug called or referred to as rizapine. Have you heard about a drug called rizapine? Rizapine, yeah, and the spelling is Reza. Rizapine, yeah. That is another example of a drug that basically works in this kind of manner. But however, it works slightly different. It works slightly differently. This is how it works. When it is given, when it basically given, remember we said, just to take you a little back, during the synthesis of norepinephrine, dopamine is pumped into the vesicles. Dopamine is pumped into the vesicles and later converted into norepinephrine. Yeah, dopamine is pumped into the vesicles and later converted into norepinephrine. However, when this drug risapine is given, what it actually does when risapine is given, allow me to rub off this. Yeah, when risapine is given, when we give risapine, what actually happens is that at the point where you have dopamine being pumped into the vesicles, yeah. Remember we said those monoamine transport mechanisms, yeah. So the monoamine transport mechanisms basically transport the dopamine into the vesicles, ready to be converted into norepinephrine, yeah. Now, what risapine does is that it interferes with these pumps, yeah, the monoamine oxidase transport mechanisms, yeah. It interferes with these pumps that basically pump dopamine into the vesicles, yeah. It interferes. Risapine interferes with the pumps that pump dopamine into the vesicles, yeah? And as a result, what happens is that this dopamine will not be pumped into the vesicles. And as a result, it is destroyed by MAO. Remember monoamines, examples of monoamines, we have norepinephrine, we have serotonin, and we have dopamine. Those are examples. You will study this more in psychiatric pharmacology. Yeah, but examples of monoamines are those ones that we have said. Now, monoamine oxidase, it basically destroys monoamines. Yeah, it destroys monoamines. So it will destroy dopamine when given chance. It will destroy norepinephrine when given chance. It will also destroy serotonin when given chance. Yeah. So if this dopamine is not being transported into the vesicles, it is basically it will be destroyed by monoamine oxidase inhibitors. Yeah, monoamine oxidase inhibitors. Rather, no. It will be destroyed by monoamine oxidase. Yeah, it will be destroyed by MAO. And so, what happens? Since dopamine is not being pumped into the vesicles, shall we have norepinephrine? No, we shall not have norepinephrine because dopamine is not pumped into the vesicles and later converted into norepinephrine. So when an action potential happens, these vesicles are basically empty. Yeah. When an action potential happens, these vesicles will release nothing. They will not release anything. And as a result, nothing will come out. Yeah. And as a result, we shall not have any action. We shall not have any effect. Yeah, because of no norepinephrine. And as a result, ladies and gentlemen, since we do not have norepinephrine, therefore our vessels will stay what? They will stay dilated, and as a result, the overall effect will be a decrease in blood, a decrease in blood pressure. Yeah. All right. So another drug another drug, yeah, another drug which is of also of clinical importance that works in a slightly different way is what we call metyrosine. Metyrosine is another drug that works in a slightly different way, and that is metyrosine. It also works at this point, yeah, but it works in a slightly different way. That drug is metyrosine. Metyrosine, yeah, metyrosine. Now, how does metyrosine work? Yeah, metyrosine basically blocks and inhibits the enzyme tyrosine hydroxylase, yeah, and therefore once it inhibits the enzyme tyrosine hydroxylase, then you will not have methyl, you will not have norepinephrine being manufactured, yeah. So we are saying that metyrosine, what metyrosine does, is to inhibit this enzyme, yeah, this enzyme that converts tyrosine into dopa, yeah. So so tyrosine to dopa. So the enzyme that converts tyrosine to dopa here is called tyrosine hydroxylase. Tyrosine hydroxylase. Yeah. So what metyrosine does is that it inhibits this enzyme here. Yeah. And once it inhibits that enzyme, then that basically means you will not have dopa being formed, and eventually you will not have norepinephrine being formed. And as a result, you will not have, when an actional potential happens, there will be no release of norepinephrine. And so the effects will be that if there is no norepinephrine, therefore you'll have a reduction in blood pressure, yeah, and you'll have an overall reduction in blood pressure. Now, the other thing that I should mention, ladies and gentlemen, is you should not be confused. When these drugs are given, or when these drugs are given, it's not that they cause inhibition of all the neurons, and you don't have any release of norepinephrine. No, that's not the fact. They basically cause a significant number, inhibit a significant number, but not everything. Otherwise, if they do that, then your whole cardiovascular system would crash. Yeah, so they don't completely cut off everything. Yeah, they don't completely cut off everything. Instead, they reduce a significant number. Yeah. So when we say here that it prevents conversion, and so you will not have norepinephrine, it doesn't mean that you will completely not have any norepinephrine in the body, and as a result, no sympathetic activity. No, it is basically a reduction. Yeah, a reduction. Yeah. So please, you should note that as well. Yeah. All right. So we have looked at these drugs referred to as the postganglionic sympathetic nerve ending blockers. Postganglionic sympathetic nerve ending blockers. Yeah, postganglia. This is the postganglia. Yeah, postganglionic nerve ending blockers and sympathetic nerve ending blockers. And of course, we've looked at drugs like rizapine. We have looked at drugs like metyrosine, and we have looked at drugs like guanadrel. Yeah, so that is basically their mechanism of action. Yeah. All right. So next, we want to talk about drugs that are referred to as adrenergic, adrenergic receptor blockers. Yeah, adrenergic receptor blockers. I hope you still remember adrenergic receptors. Yeah, these are basically receptors of the sympathetic nervous system, and they are basically two types. We have alpha and beta. Yeah, and so alpha is divided into alpha 2 and alpha 1, and then beta is also divided into beta 1 and beta 2, as we are going to see. So well, the other type are those ones that we are going to talk about, and those are the alpha, rather the adrenergic receptor blockers. And once we talk about adrenergic receptor blockers, we basically are referring at this point here. We are referring at points when we talk about adrenergic, adrenergic receptor blockers, we mean those points where adrenergic receptors are located. Yeah, and so it can be here, it can be here, it can be on the arterioles, and also it can be on the juxtaglomerular apparatus. Yeah, so the point to take home is that adrenergic receptors are widely distributed. Yeah, and once they are blocked, yeah, then we have a significant reduction in pressure. Yeah. So when we talk about adrenergic receptor blockers, yeah, when norepinephrine is released, yeah, when norepinephrine is released, basically it acts on the nerve, on the effector organs, yeah, because there are receptors there. Yeah, so when you have release of norepinephrine, that norepinephrine is supposed to act on receptors on the different effector organs. So those effector organs can be in the heart, they can be on the blood vessels, they can be in the kidneys, on the juxtaglomerular. Yeah. So when it is released, it acts on those receptors. Yeah. Now in the heart, basically we have what we call the beta 1. Yeah. I hope you still remember that. Yeah. In the heart, we have what we call the beta 1 adrenergic receptors. Beta 1. Yeah. So these are located in the heart. If you have forgotten, please go ahead and do a recap of the distribution of adrenergic receptors throughout the body. You will find out that in the heart we have beta 1 adrenergic receptors. Yeah, and then on the veins and the arterioles, on the veins and arterioles, we have alpha 1 receptors. Yeah, we have alpha 1 receptors. On the veins and arterioles, we have alpha 1 receptors. So when we block these, it basically means then we shall have a reduction in sympathetic activity, and therefore a reduction in blood pressure. Yeah. So we want to talk about these. Yeah, adrenergic receptor blockers. Adrenergic receptor blockers. So again, adrenergic receptor blockers. Yeah. So adrenergic receptor blockers, these are basically, as we said, they are what we call the alpha. We have what we call the alpha, and of course the alpha and the beta. Yeah, and so among the alpha blockers, we have those that are referred to as selective and non-selective. We have the selective alpha blockers and the non-selective alpha blockers. Yeah. Remember we are talking. Remember we said in the heart we have beta. Yeah. And in the blood vessels we have alpha 1. Yeah. Now I hope you know, or I hope you remember where the alpha 2 are located. And I hope you still know where the beta 2 receptors are located. Of course, one of the most prevalent places is within the respiratory tract. That's where we find beta 2 receptors. So our main interest in this topic, we shall concentrate on the beta 1 and the alphas, yeah, especially the alpha 1, yeah, alpha 1, receptor blockers. But we are saying that among the alpha blockers, among the alpha adrenergic receptor blockers, we have those that are non-selective, by non-selective, it basically means they can inhibit, alpha 1 and alpha 2. Yeah, so they inhibit alpha 1 and alpha 2. Yeah, so that is what it means by a non-selective. Yeah, then we also have what we call the selective, selective alpha 1, blockers. So in other words, these ones only and only inhibit alpha 1 only. And so for that matter, they are called selective. Yeah. Now, let's so the non-selective. Let's first talk about the non-selective. Yeah. The non-selective, basically, these block both alpha 1 and alpha 2. They block both alpha 1 and alpha 2. Now, let us explain. I want to explain something here. Yeah. I want to explain something here briefly. Yeah. So when you have the non-selective, yeah, we are saying that these ones basically, of course, non-selective alpha blockers, yeah, these ones basically will block what and what? They will block alpha 1, and alpha what? Alpha 2, yeah? And the selective will only block alpha 1. And of course, examples of these drugs like phenoxybenzamine. Examples are phenoxybenzamine and phentolamine, yeah, phentolamine. Phentolamine, yeah. So these are the examples of alpha, of non-selective alpha blockers, yeah, phentolamine and phenoxybenzamine. However, it is important for you to know that these drugs are not widely used. These drugs are not widely used. Can you basically think of a reason why they are not widely used? Yes, because they block. Because they, instead of blocking only these, yeah, they block even. Remember, we said these are located on the veins and on the arterioles, yeah, on the veins and the arterioles. So when they block that, it basically means you will have vessel dilatation, yeah. However, look here, very, very critically, yeah. When you block alpha 2, where did we say alpha 2 are situated? When you block alpha 2, remember we said alpha 2 are situated on the some most alpha 2 are situated on the on the nerve endings, yeah, the preganglionic nerve endings. So you have alpha 2 here, yeah. So if you have a drug, that blocks, yeah, alpha 2, what does that mean? If it blocks alpha 2, then it basically means that norepinephrine will continually be released. Does it make sense? Remember we said alpha 2, when they are stimulated, when alpha 2 are stimulated, they basically cause a negative feedback mechanism. Yeah, when alpha 2 are stimulated, they cause a negative feedback mechanism which stops release of norepinephrine. Is that clear? So when we have a drug that blocks alpha 2, it basically means that since it is blocking alpha 2, yeah, there will not be negative feedback mechanism, and therefore norepinephrine will continually be released. And as a result, you'll have adverse effects like palpitations, tachycardia, and all those things. Yeah. So basically, that is why non-selective alpha blockers are not are not used so much. Is that clear? Right. Now, remember we said the examples, phentolamine and phenoxypenzamine. Yeah. Now, the other drugs that we want to look at are what we call the selective alpha 1. Yeah. Selective. For them, they are selective. In other words, they only block alpha 1. Yeah. And the examples here are the zosins. I don't know whether you've heard about the zosins. Prazosin, terazocin, dexazocin, yeah. So the zosins, yeah. The zosins, you have a name, you have a whatever, and then zosin, something like that, yeah. So the zosins examples is prazosin, prazosin. You have terazocin, and then dexazocin. So the zosins are examples of alpha 1, selective alpha 1 blockers. By the way, these are also important. They are basically used also in in treatment of symptomatic treatment of people who have BPH. Yeah, because once they are blocked, they basically cause relaxation of the muscles, the smooth muscles. Yeah. So those are what we refer to as the selective alpha 1 blockers. Of course, if they block the alpha 1 receptors, that basically means there will not be stimulation. Yeah, because alpha 1 receptors are stimulatory. Yeah, alpha 1 receptors are stimulatory, while alpha 2 receptors are inhibitory. Yeah, please note that alpha 1 receptors are stimulatory. Yeah, while alpha 2 receptors are inhibitors. So if they are blocked here, they will basically be things like vasodilatation, since we are not having stimulation, yeah, something like that. So basically, those are what we refer to as the selective alpha 1, blockers, yeah. And examples are the zosins. Examples are the zosins, yeah. All right. So so basically that is what we have. Those are the two other categories of drugs, yeah, that we talked about. We remember the first ones were the postganglionic sympathetic nerve ending blockers, of which of course we gave examples, and then the other category were the adrenergic, the adrenergic receptor blockers, and of course we have among the adrenergic receptor blockers, we said we have the alpha, yeah, the alpha blockers, where we have the non-selective and the selective. The non-selective, these ones basically block alpha 1 and alpha 2, yeah, and they are not so much used, yeah, because of their blocking of alpha 2, yeah, a phenomenon that I have just explained, yeah. Now the selective alpha blockers are the ones that are usually used, yeah. They are the ones that are usually used because of their selectivity, yeah. Because of their selectivity, they are widely used. Okay. Now, the other examples of adrenergic receptor blockers are the beta blockers. These are very easy for you to remember. Yeah. So the beta blockers basically they block the beta receptors. Yeah. So they block the beta receptors, and we said we have beta 1 in the heart. Yeah, we have beta 1 in the heart. But not only do we have beta 1 in the heart only, but we also have them in the juxtaglomerular apparatus. Yeah, we have them in the juxtaglomerular apparatus. So beta blockers. Now beta blockers can also be divided into what we call selective, yeah, selective beta blockers, and the non-selective, beta blockers. So we have the selective, and then the non. We have the selective and the non-selective. Examples of selective are examples like atenolol. So the LOLs, by the way, LOLs, when we talk about beta blockers, LOL, yeah, it is LOL, yeah, those LOLs, yeah, LOLs, atenolol, propranolol, carvedilol, all those are beta blockers, yeah, but specifically the selective beta blocker, in other words, it is selective for beta 1, yeah, it is selective for beta 1 is atenolol, yeah, and then the non-selective here is an example of propranolol, yeah, propranolol. Now, so this one, it is non-selective, and therefore it inhibits both beta 1 and beta 2. Remember, I said beta 2 is in the respiratory tract. Yeah. So when it is inhibited, it basically causes constriction. That is why we don't advise to give propranolol in asthmatics for this reason. Yeah, because it is a non-selective beta blocker. So it will end up blocking the beta 2. Yeah, it will end up blocking the beta 2. And once it blocks the beta 2, we shall have bronchoconstriction. Yeah, we shall have bronchoconstriction. Therefore, it's not advisable to be given in people who have asthma or people who have any respiratory kind of condition like COPD. Yeah. All right. And then, so beta receptors, beta 1 receptors, as we say, they are present within the heart. Yeah. Beta 1 receptors are present within the heart. So if this is our heart, so you have beta 1 receptors at the sun, you have beta receptors at the AVN, and then you have them throughout, throughout the myocardium, yeah, beta 1, yeah, beta 1. So you have them located almost throughout the heart. So if you give a beta blocker, what actually happens is that one, it will reduce the firing by the sun, yeah. If it is, and therefore the heart rate will decrease, yeah. It will decrease the heart rate, yeah, because of reduction of the firing by the sun and also conduction through the AVN. So it will end up decreasing the heart rate. It will also end up decreasing the what? The contractility, yes. So when you give a beta blocker, it will decrease the heart rate, but also decrease the contractility of the heart. And therefore, remember we said once we have a reduction in heart rate, we shall have a reduction in blood pressure. Once you have a reduction in contractility, therefore we shall have a reduction in blood pressure. Now, beta-1 receptors are not only located in the heart, but they are also located in the juxtaglomerular apparatus. Yeah, the juxtaglomerular apparatus. Yeah, and of course, once they are stimulated, once the beta-1 receptors are stimulated, then they will cause activation of the of the RAS, the renin-angiotensin aldosterone system. Yeah, we shall talk about that in a minute. Yeah. So if we give a beta blocker, beta-1 blocker, not only will it inhibit the heart, but also will inhibit the the RAS, yeah, the RAS in the juxtaglomerular apparatus of the kidney. Yeah. So basically, and eventually we shall have a reduction in blood pressure. Maybe what is RAS? Let's talk about this. Let's just briefly talk about the RAS. The RAS is referred to as renin angiotensin aldosterone system. Yeah, renin-angiotensin aldosterone system. I've already talked about it in the presentation on hypertension, but we can still do a recap on it. Now, the renin-angiotensin aldosterone system. This renin is basically produced, yeah, in the juxtaglomerular apparatus, yeah, of the within the kidneys in the distal, the distal tubule, yeah, of the nephron, yeah. So produced in the juxtaglomerular apparatus, yeah, which is located, yeah, in the in the nephron, in the distal tubule of the what of the nephron, yeah. Now it produces renin, yeah. Once it produces renin, this renin basically causes conversion of angiotensinogen. Now, this angiotensinogen is basically produced in the liver and it is freely circulating. Yeah, so it is produced in the liver by the liver and it is freely circulating. So the renin converts this angiotensinogen to angiotensin 1. Yeah, it converts this angiotensin to angiotensinogen to angiotensin 1, and then this angiotensin 1 is converted to angiotensin 2 by an enzyme called angiotensin converting enzyme, which is produced, within the lungs, the pulmonary, trunk. Yeah. So it is produced within the lungs, and it basically causes conversion of angiotensin 1 to angiotensin 2. Yeah. Now this angiotensin 2 is a very potent vasoconstrictor. Yeah. But not only does it do vasoconstriction, it also does other things, as we shall see. Yeah. Now, so remember we said we also have beta 1 on the juxtaglomerular apparatus. Yeah. So once we have blockade, yeah, once we have blockage, so we shall not basically have we shall not have renin being released, and therefore eventual production of angiotensin 2. Yeah. So again, we shall have a reduction in blood pressure. Yeah. So basically, that is what alpha blockers, beta blockers do. And so we also have what we call mixed blockers. Yeah, mixed blockers. These ones basically block alpha 1 and beta 1. Yeah, mixed blockers Remember, we talked about selective and non-selective beta blockers, yeah? And then we also have mixed blockers, yeah? Mixed blockers, mixed blockers. Mixed blockers, these ones basically block alpha 1 and beta. So they block these two, yeah? They block alpha 1 and beta 1. And examples of these are carvedilol and labetalol. So those are mixed, mixed mixed blockers. Those are carvedilol and labetalol. Yeah. Okay. So basically, those are that is another. Those are the another two types of antihypertensives. Yeah, and so we have we since the beginning of this lecture, we talked about the postganglionic sympathetic nerve ending blockers, yeah, and of course we gave examples, and then we also talked about the we also talked about the adrenergic, yeah, adrenergic receptor blockers, of which they were divided into the alpha blockers, and then of course these were the selective and non-selective, and then the beta blockers. Of course, beta blockers, you have selective, non-selective, and mixed blockers. In our next video, we shall continue with another group of antihypertensives, and these will be basically the directly acting vasodilators.